right now, up to 20% of women are suffering from a condition that, well, modern medicine historically prefers to just whisper about or, ignore entirely.
Yeah, if it even acknowledges it at all.
Yeah.
It's incredibly frustrating.
Exactly. It's a type of pain that can completely dismantle relationships. It severely impacts mental health, and yet so many people are simply told that it's just a normal part of aging or like something you just have to deal with postpartum.
Right. Which is just not true.
No, it's not. And the clinical term for it is dyspareunia, or in plain English, painful sex. So today we are doing a deep dive into why this diagnostic landscape is so shrouded in silence. And we really want to look at whether this highly buzzed about futuristic regenerative treatment known as the O-shot, which uses platelet-rich plasma, or PRP, can actually fix the problem.
It's an incredibly revealing area of medicine right now, I have to say, because, we are looking at a condition that sits right at this really complex intersection of raw biology, deeply ingrained psychology, and then, of course, cutting-edge biotechnology.
And we have quite the stack of sources to guide us through this today. We're pulling from the UK's NICE guidelines, systematic reviews from the Cochrane Library, various clinical trial listings, and detailed literature from private women's health clinics.
So we really have a wide spectrum of data to pull from.
Yeah, we are trying to understand this from every possible angle for you. So, okay, let's unpack this, because before we can talk about spinning blood and injecting it as a cure, we really have to understand the pain itself.
Absolutely. You can't treat what you don't define.
Right. And going through the clinical classifications, it really struck me that dyspareunia isn't just one monolithic experience. It's not just a single type of pain.
No, not at all. And the clinical pathways heavily emphasize that distinction. It's primarily categorized by where the pain occurs and when it actually started. So let's look at location first.
Okay.
First, you have superficial dyspareunia, which basically refers to entry pain. If you're experiencing this, the pain is localized right at the vulva or the vaginal entrance, which clinically is known as the introitus.
And the descriptions from the patients in the literature are so highly specific. Like, they often describe it as a severe burning sensation. Or, my sources said it feels like a raw paper cut the absolute second that touch occurs.
Yes, exactly. A raw paper cut.
Just the imagery of that immediately communicates how visceral this is. It makes complete sense why a doctor hearing that would be pointed toward, localized skin issues or heightened nerve sensitivity.
Right, because it's right at the surface.
True.
But then the sources also describe deep dyspareunia, which sounds mechanically entirely different.
Yeah, because it involves completely different biological structures. Deep dyspareunia is experienced much higher up in the vaginal canal or deep within the pelvic cavity itself.
Usually during thrusting, right?
Exactly, typically specifically during thrusting. And if a patient reports this, they usually describe a deep ache, like a bruised feeling or what they call a collision pain.
A collision pain. Well,
Yeah. And when a physician hears those specific words, they immediately stop looking at the superficial skin. They have to start looking at internal organs.
like checking for irritation of the uterus or the ovaries.
Exactly. Or looking for severe inflammatory conditions, like endometriosis and adenomyosis.
So beyond just where the pain is located, the sources place this massive emphasis on the timeline as well. They differentiate between primary and secondary onset.
Which seems crucial for figuring out the root cause,
All right, the timeline often gives us the why. So primary onset means this pain has been present since the very first attempt at penetration in a person's life.
Like literally from day one.
Yes. And that naturally directs medical attention toward congenital structural factors or early onset involuntary muscle spasms. But then you have secondary onset, which is statistically much more common.
And that means you develop the pain after a period of completely pain-free sexual activity, right?
Correct. And in those cases, we look for a specific triggering event. It frequently follows things like childbirth, pelvic surgery, a really severe infection, or, the onset of menopause.
But reading through the psychological literature in our stack, the physical location and the timeline, they only make up half the story.
Oh, absolutely. The brain plays a huge role.
Because the brain gets involved and it creates this incredibly powerful, almost inescapable feedback loop.
The literature actually refers to this as the fear avoidance model of pain. And honestly, if you want to understand dyspareunia, you really have to understand this mechanism.
It's fascinating. Tell us how that works.
Well, when you experience a negative, highly painful event with penetration, your brain naturally registers that specific action as profound danger. I mean, it's a threat.
It's trying to keep you safe.
Exactly. But this leads to catastrophic thinking, which then generates a severe underlying fear of any future penetration.
Yeah.
And that fear instantly triggers hypervigilance in the nervous system.
It's kind of like when you burn your hand on a hot stove, right? The next time you are anywhere near that burner, your whole body involuntarily tenses up in anticipation.
That's a perfect analogy.
Your brain is just doing its job. It's trying to protect you from harm. But in the case of intimate pain, that specific protection mechanism is actually what causes the ongoing damage.
Yes, and that physical tensing mechanism in the pelvic region is known as muscle guarding, or clinically it's called vaginismus.
Right.
The pelvic floor muscles involuntarily and forcefully contract to essentially close off the entrance. It acts like a barricade against perceived harm.
And if penetration is attempted while those muscles are locked down like that,
The friction causes severe pain. It literally causes microscopic tearing in the tissue and an immediate biological loss of arousal and natural lubrication.
which unfortunately just provides the brain with the exact confirmation it was looking for, doesn't it?
Exactly. The brain goes, see,
Yeah.
I told you this was going to be excruciating.
And the cycle just brutally reinforces itself. I mean, if you are living with that, the exhaustion must just be overwhelming.
It really is.
So, if the body is actively guarding itself and trapped in this neurological loop, how does the medical world try to dismantle that alarm system? I mean, before reaching for something as invasive as needles.
Well, the prevailing medical protocols, like the NICE guidelines in the UK, for instance, strongly advocate for what they call a stepped pathway of care.
Meaning you start small.
Exactly. The mandate is to always exhaust the most conservative foundational options first, just to see if the tissue can be rehabilitated non-invasively.
And one of the most practical things I found in those guidelines was this surprisingly rigid distinction between moisturizers and lubricants.
Yes, people often confuse them.
I think a lot of people assume they are basically interchangeable products, but the clinical application is totally different, right?
The mechanisms of action are completely distinct. Vaginal moisturizers, particularly the ones formulated with hyaluronic acid, they're designed to be absorbed into the tissue.
Because hyaluronic acid is incredible at binding water to cells.
Right, so you use these regularly, maybe several times a week, independently of sexual activity. The goal is just to maintain day-to-day cellular hydration and elasticity.
Whereas lubricants, conversely, sit on top of the tissue.
Exactly. They are applied specifically at the moment of sexual activity, solely to reduce surface friction.
And the sources get very granular about which lubricants to use, too. Like, they explicitly warn against oil-based lubes if you are using latex condoms or certain toys.
Because the oil chemically degrades the latex. It just causes it to break down.
Right, so they push water-based for general versatility, but they specifically highlight silicone-based lubes for dyspareunia because silicone doesn't absorb into the skin.
Yeah, it just stays on the surface, which provides a much longer lasting glide. And that is critical if the entrance is already tender and prone to those micro tears we talked about.
Now, if those foundational steps, the hydration and friction management, if they fail to provide relief, the pathway scales up. It moves to address the underlying hormonal biology.
Which is particularly relevant for women experiencing genitourinary syndrome of menopause, or GSM.
I was actually reading the Cochrane reviews on GSM, and the biology of what happens when estrogen drops is stark.
It's very dramatic.
The vaginal tissues don't just feel dry, they physically change. They literally thin out, lose their natural elasticity, and they become incredibly fragile.
Without estrogen, the vaginal mucosa loses glycogen, and that alters the local pH and completely diminishes the tissue's structural integrity.
Wow.
So the gold standard treatment here, and this is heavily supported by systematic reviews, is localized vaginal estrogen.
Administered via small creams or tablets.
Creams, tablets, or even slow-release rings placed directly into the vagina. And the brilliance of this approach is that it restores the tissue architecture locally without flooding the patient's entire systemic bloodstream with hormones.
Which is a big relief for a lot of people. And there are also alternatives, right? Like vaginal DHEA or an oral medication called ospemifene.
Yes, ospemifene is an interesting one.
I want to touch on ospemifene because the mechanism is fascinating. It's a pill, but it isn't actually estrogen. It's a SERM, a selective estrogen receptor modulator.
Right.
Essentially, it travels through the body and specifically tricks the estrogen receptors in the vaginal tissue into turning on, but without stimulating receptors in breast tissue.
That's the selective part. Though the clinical trials did note a pretty significant caveat.
Yeah, doctors have to monitor the patient closely because it can sometimes trigger an unwanted thickening of the endometrial lining in the uterus.
That monitoring is non-negotiable. And while we rebuild the tissue chemically with these options, we also have to address the muscular barricade we talked about earlier.
The vaginismus.
Exactly. If the root cause of the pain is that involuntary muscle guarding, all the estrogen and hyaluronic acid in the world won't force those muscles to relax.
It's just a physical lock.
Right. That requires specialized pelvic floor physical therapy. It involves neuromuscular downtraining, literally teaching the pelvic floor how to release.
And utilizing guided dilator work I saw in the sources.
Yes, so the brain can slowly uncouple the sensation of penetration from the expectation of severe pain.
Okay, I have to push back here for a second.
Go ahead.
If we have this massive, highly researched arsenal daily hyaluronic moisturizers, bespoke friction management, local estrogen, DHEA, receptor modulators, and specialized physical therapy, and all of this is backed by heavy hitters like a Cochrane library.
Right.
Why do we even need something like the O-shot? Are we just inventing expensive, futuristic procedures to market to people who are desperate for a fix?
That is such a common reaction. It raises an important question, and looking at the sheer volume of available treatments, your skepticism is entirely warranted.
It just seems like so much.
It is.
Yeah,
However,
man.
we have to look at the patients who fall through the cracks of those exact protocols. Local estrogen works wonders, but not everyone is a candidate for it.
Like breast cancer survivors.
Exactly.
Mhm.
Breast cancer survivors, specifically those who had hormone receptor-positive cancers, are often strictly advised by their oncologists to avoid any form of estrogen, even localized.
Oh, wow. I hadn't thought about that.
And other patients simply decline hormone therapy due to the perceived risk profile. But more frustratingly, there is a distinct subset of patients who do everything right. They use the moisturizers, they apply the estrogen, they do the physical therapy,
And it still doesn't work.
and they still suffer from persistent burning at the vestibule and chronic microtears.
So they basically hit a therapeutic wall. They've exhausted the stepped pathway, and the pain is still there.
They hit a wall where traditional medicine essentially runs out of options. And that specific void in clinical care is where regenerative autologous medicine steps in.
Okay.
It operates on a completely different biological axis than hormone replacement or physical therapy.
So here's where it gets really interesting. Let's talk about the actual science of platelet-rich plasma, or PRP.
Let's do it.
Because I was looking into how these private clinics process this, and I honestly didn't realize how precise the technology has to be. You go in, and they draw a small vial of your blood.
Right, just a standard blood draw.
But then they put it into a highly specialized dual-spin centrifuge. The literature highlighted systems like the M-site centrifuge, which spins the blood with such specific velocity that it physically separates and removes 99% of the red blood cells.
Removing those red blood cells is the critical step.
Why is that?
Well, red blood cells are highly inflammatory. If you inject them into delicate tissue, they cause immense pain and swelling. So by isolating them out, you are left with a highly concentrated serum of purely platelets and plasma.
The so-called liquid gold.
Exactly. The liquid gold.
But why platelets? Why is the medical community so relentlessly focused on concentrating them?
Think of platelets as the body's microscopic construction foreman. In a normal biological scenario, if you suffer a deep cut, platelets are the first responders.
They rush to the injury.
Right. They rush to the site of the injury, assess the damage, and immediately start releasing bioactive proteins and growth factors. These growth factors signal the local dormant stem cells to wake up and start repairing the area.
Okay, so by extracting them, concentrating them, and then injecting them into the vaginal tissue, you are essentially tricking the body.
In a way, yeah.
You are sending in an army of construction foremen who blast their biological flare guns, convincing the body there has been a massive injury that requires urgent repair.
Even though there is no actual wound.
Right, you're flooding the area with regenerative resources.
And the cellular cascade that follows is remarkable. Once injected into targeted areas like the clitoris, the anterior vaginal wall, and the labia, those growth factors promote angiogenesis.
Which is the creation of new blood vessels, right?
Exactly. It's the literal creation of brand new blood vessel networks. They also trigger profound collagen remodeling, which thickens and strengthens fragile mucosal tissue. And they stimulate local nerve regeneration.
So it isn't just a Band-Aid. It isn't masking the pain signals with a numbing agent. It is hijacking the body's own repair mechanisms to rebuild the compromised tissue infrastructure from the inside out.
That's the perfect way to put it. Rebuilding from the inside out.
And the clinics claim this increased microcirculation naturally boosts lubrication and heightens sensitivity. But there was one secondary benefit in the sources that I definitely needed clarification on.
Oh, the incontinence benefit.
Yeah. They mentioned that injecting PRP into the anterior vaginal wall tightens the periurethral sling, which supposedly cures mild stress urinary incontinence. You know, that annoying bladder leakage when you cough or jump.
Very common.
But what exactly is a periurethral sling?
So imagine a small muscular hammock made of connective tissue. It sits right underneath your urethra and bladder neck. Its whole job is to provide support and keep everything closed when downward pressure occurs.
Like during a cough or a sneeze.
Right. But as we age, or often after childbirth, that tissue hammock sags and loses its collagen strength.
Oh, I see.
So by injecting PRP into the anterior vaginal wall, the resulting burst of new collagen tightens and thickens that hammock. It basically provides the mechanical support the urethra was missing.
That dual action benefit makes complete sense as to why this is gaining so much traction. But I really have to ask the highly practical, entirely squeamish question that I know you were thinking about as you listen to this.
I think I know what's coming.
We are talking about taking a hypodermic needle and injecting it into the absolute most sensitive, nerve-dense erogenous zones on the human body to stop pain.
Right.
If a patient is already trapped in a fear avoidance loop of pain, how does a doctor approach them with a needle without sending them into a full-blown panic attack?
It's a very valid concern.
Yeah.
And the clinical protocols for comfort are incredibly rigorous for exactly that reason. A patient does not just walk into the room, lie back, and receive an injection.
Thank goodness.
A high-strength, specialized topical numbing cream is applied comprehensively to the entire vulvar and vaginal area. And crucially, it is left on for a full 45 minutes prior to any procedure.
45 minutes is a significant amount of time for a topical anesthetic to absorb. That would deeply numb the superficial nerves.
It absolutely does. Furthermore, many physicians combine that numbing protocol with vibration analgesia.
What is that?
They place a vibrating tool adjacent to the injection site. The vibration signals actually travel to the brain faster than the pain signals, effectively confusing and distracting the local nerve endings.
Oh, wow. That's clever.
And in more severe cases of hyperalgesia, they might even administer a targeted nerve block. Across the clinical data, patients consistently rate the actual pain of the O shot at about a 2 out of 10.
Just a 2.
Yeah, they report feeling a sensation of pressure, a brief pinch, or a warm flushing feeling, rather than sharp, acute pain.
Okay, so a 2 out of 10 on the pain scale and a really efficient procedure time. If the science is this elegant and the pain of the procedure is that minimal, why isn't this the standard first-line treatment?
Instead of making women go through months of estrogen therapy.
Yeah, and physical therapy. What does the hard evidence actually say about its efficacy right now?
What's fascinating here is that while the clinical data is highly promising, it really requires significant nuance. We do have early clinical trials, including randomized control trials, that show statistically significant improvements in what we call VAS scores.
Those are visual analog scale pain measurements, right?
Yes. Women undergoing PRP treatments demonstrate marked, measurable reductions in dyspareunia and burning sensations when monitored over 8 to 12-week periods compared to their baselines.
But those studies aren't enough to completely rewrite the medical guidelines just yet.
No, they aren't. The scientific consensus right now is that the available studies are still relatively small and highly heterogeneous.
Meaning they aren't standardized.
Exactly. One clinic might prepare the PRP slightly differently than another. They might inject varying volumes, and they track patients over differing timeframes.
So the data is a bit all over the place.
Because the standardization isn't fully locked in across the globe, the broader medical community currently classifies the O-shot as an adjunct therapy, not a primary standalone cure.
It's an extra tool in the toolbox.
A very powerful tool. But we need large-scale, long-term, highly standardized trials to definitively map its efficacy.
So if a patient hears that this is an effective, non-hormonal adjunct and decides they want to pursue it, the immediate question is accessibility and logistics.
Always.
In the UK, the private clinic literature prices this out-of-pocket procedure between £1,150 and £1,425.
It is an investment.
But managing expectations on the timeline seems critical here, too. I mean, if you are relying on the slow growth of new blood vessels, you aren't going to walk out of the clinic magically cured that afternoon.
No, definitely not.
Oh.
The biological reality is that tissue regeneration is very gradual. Patients typically begin noticing subtle shifts in lubrication and comfort between 2 to 6 weeks.
And when do they see the full result?
The full regenerative effects usually peak around the 3-month mark.
And how long does that peak functionality last before the body resets?
Roughly 12 to 18 months. because the underlying systemic drivers of tissue aging, like the persistent lack of circulating estrogen we talked about, are still very much present.
So the PRP is essentially rejuvenating the tissue locally, but the biological aging process just continues.
Exactly. Consequently, many women incorporate an annual or 18-month booster shot to maintain the tissue integrity.
One aspect of the logistics that genuinely surprised me was the downtime. Because it is autologous, meaning the material comes from your own body, the risk of allergic reaction or rejection is functionally zero.
Right, it's your own blood.
The clinics state you can theoretically resume sexual intimacy the exact same day, though they do allow waiting 24 to 48 hours just to allow any temporary swelling to subside.
Which is pretty standard.
But safety in regenerative medicine isn't just about avoiding allergic reactions. There are intense legal regulations about exactly who is allowed to hold that needle.
Oh, this is a vital warning for anyone looking into regenerative treatments. The moment a procedure involves drawing, processing, and re-injecting human blood, it falls under incredibly strict medical safety, infection control, and blood handling regulations.
The sources included a really illuminating update from the General Chiropractic Council, the GCC in the UK, which serves as a perfect example of this.
Yes, that was a major
They
ruling.
had to issue a formal ruling explicitly stating that chiropractors are legally forbidden from manufacturing or injecting PRP.
Because the legal framework is very clear. Medical doctors and certain dentists hold specific exemptions under the human medicines regulations that allow them to process blood for immediate autologous use.
But other practitioners simply do not.
No. The GCC highlighted that any chiropractor attempting to offer PRP is operating outside the law because they lack the necessary authorizations under the blood safety and quality regulations.
Which is a stark reminder that the science is only as safe as the regulatory environment it's performed in. If you are exploring this, you absolutely must ensure you are consulting a regulated GMC-registered doctor or a fully licensed medical equivalent operating in a CQC-regulated clinic.
You definitely do not want to go to a strip mall med spa with vague credentials when your blood and your most intimate anatomy are involved.
Exactly. Without strict adherence to infection control and proper centrifugation protocols, the risks vastly outweigh the potential benefits.
Absolutely.
So what does this all mean for you navigating this landscape today? We've unpacked a massive amount of clinical information here.
You really have.
Dyspareunia is not a simple mechanical failure. It is a complex, often silent struggle that operates on a relentless feedback loop of physical pain and psychological fear.
And the most important takeaway from all these sources is that you do not have to suffer in silence. And you certainly do not have to accept pain as your permanent reality.
The foundational interventions, consistent cellular hydration with hyaluronic acid, targeted friction management, local estrogen therapy, and neuromuscular pelvic floor training, those remain your crucial first line of defense.
They are rigorously tested and highly effective for the vast majority of patients.
But if you reach the end of that pathway, if hormones are medically off the table for you, or if the microtears just refuse to heal, the O-shot offers a deeply fascinating science-backed adjunct.
It bypasses synthetic interventions by utilizing your body's own localized healing mechanisms to rebuild that vulnerable tissue from the inside out.
It's incredible science.
It is. And if we connect this to the bigger picture, right now, we are isolating the regenerative components of our own blood to heal intimate pain and rebuild fragile tissue. But it forces us to look at the entire trajectory of modern medicine. As regenerative autologous therapies become increasingly advanced, how much of our future medical care for cellular aging, for chronic inflammation, and for sexual health will rely not on synthetic drugs manufactured in a lab, but on unlocking the customized, perfectly matched pharmacies already flowing through our own veins?
Unlocking our own biology, that is a profound place to leave it for today. Until next time.